Afternoon, everyone. My name's Richard. I'm a plastic surgeon here at Middlemore. I'm also the clinical leader for the National Burn Service. Clinical leader because that way you don't have to pay me. My talk is about major burn injuries and how the National Burn Centre and the National Burn Service fits in there. Apparently, I have to begin with a disclaimer. I was going to say I'm just conflicted and not interested, but these opinions are of my own, not necessarily of my department or the hospital or DHB, and I have no pecuniary interest other than this is the reason I'm employed. So you can take into that what you like. I have previously nicknamed this talk the Gambler Talk, and I find it hard to actually read through that without trying to sing it, so you can read it through with me. It's about knowing which one's hold, which one's not, okay? And I love the bit when you've got to know when to run. So what I'm going to do is talk briefly about burn injuries and then talk briefly about the referral criteria. So I've nicknamed this Lessons from MasterChef. Okay, right. So from a very simplistic point of view, your burn wound can be considered in a group of concentric areas of destruction. At ground zero, there is a zone of coagulation. This is coagulated protein. This is cooked. And as far as I know, there's no way to turn something that's cooked back into something that's raw. So it's dead, Jim. Around that is what we call the zone of stasis. This is tissue which may or may not pull through, and we see that clinically as burn depth progression. And then around that is a zone of hyperemia. This is tissue which is viable and alive, but it's essentially caught up in the crossfire. And the thing about it is, and what makes a major burn is that that zone of hyperemia, the bit that's caught in the crossfire, can be the rest of the body, right? So these patients are incredibly SIRSy. Now here it is clinically. There's a registrar who didn't listen or didn't attend a session. So that's dead, Jim. This is bits that may or may not pull through depending on how we look after it. This bit's absolutely fine, but is contributing to the inflammatory response of the patient. Okay, so how someone responds to a burn injury is basically about how much of their body's burnt and then what their reserves are. And the proxy marker for that is how old they are. And then this is the thing is that, with a small burn, it's a local problem, a wound problem. But when it gets bigger, it can become much more. It's potentially systemic, but then the patient doesn't live in isolation. It can affect their entire family. And those people who are involved in burn care will realize that, particularly, for example, a pediatric patient, the patient themselves is the easy bit. It's the rest of the family that is the real challenge. Okay, so look, the bottom line about all this is get 2 letters and a number. You've got an inflammatory mediator. Okay, I think it was said earlier today that surgeons are simple, so this is going to be really simple. And as a plastic surgeon, it's also going to be pedantic. It's probably the worst thing you can get, right? Someone who's simple but also is focused on details that are incorrect. Long story short is that because of these inflammatory mediators, fluid leaks out of the circulatory system and causes swelling. So you might see a swollen patient, but they're intravascularly dry. And what's worse is that what makes them swell is not just the burn injury, but us. Okay? And in a spare moment, if you're ever bored, what I'd suggest you do is take your smartphone out, because everyone in the world has a smartphone, right? And you can put out how much fluid everyone in this room should survive a 50% burn. Okay? So why don't you do that now? Grab your phones, pull it out. Okay? Grab your phone. I don't actually have to know how heavy you are, but the modified Parkinson formula that we're teaching now is 3 mils. So 3 times your weight in kilos, okay, times 50, which is the percent body surface area you'll have, hit equals, that is the amount of fluid in 24 hours in mils that you will get. Okay, it is probably several times your blood volume, okay, and the amount of output that we're expecting from people is just 0.5 ml per kilo per hour. So you are going to be massively fluid overloaded, massively fluid positive, and that's, you won't die of burn shock, but there are complications from over-resuscitation. This is the current understanding of what a burn injury does to a person. That's far too hard. Okay, this is MasterChef. There's not a lot difference between us and a slab of meat. And whether you slow broil it or flame grill it, you are delivering energy and denaturing protein. That is a burn injury. Okay, right. As I said, really simple. Okay, so what are you going to do with all this? This is the gambler song, right? Referral criteria. Fiona Wood, who's a good friend and also won Australian of the Year, I'm going to try and use as many quotes as I can. Quality of outcome must be worth the pain of survival. All right, there's no such thing as a minor burn, particularly when it happens to you. And any injury not treated well has the potential to cause no end of badness. And I tell my registrars, it's like clutching defeat from the jaws of victory. Okay, we've seen it. I give this talk to the Australians, they've experienced it. Okay, oh my God, how could you go from one more race? Okay, forget that. Okay, look, bad things happen. Look. Okay, so bad things can happen. And the issue that we have is that there are these little things like all bleeding will eventually stop. Well, the reality is also with a burn injury, all burn wounds will eventually heal if they don't kill you. But they don't necessarily heal up well. And by well, I mean aesthetically and functionally. Okay? And there's all these questions like, should we give every burn a chance? Our line in the sand, by the way, is 2 to 3 weeks. If a burn will not heal up within 2 to 3 weeks, you're better off with surgery. Okay? Sometimes you wait to see. Other times you can make that call straight away. And this is a hard philosophical thing for some people to get, and that's particularly surgeons. And that is that failure is not surgery, failure is scarring. Okay? And for those of you who aren't involved in surgery, think of it this way. When a patient comes into you in your emergency department and they say they are fit and well, and when you examine them, you discover they're an uncontrolled diabetic, hypertensive, and dare I say it, slightly psychotic because they haven't taken their medicines. By contrast, the little old lady comes up and gives a bag from Countdown with all their medicine, just drops it there, and your heart sinks. And you go through all the medications. But in fact, their antihypertensives is controlling their hypertension. That their blood, that their sugars are under control, and dare I say it, their psychoses are also under control. That's better life through chemistry. You can get a better life through surgery. The enemy is not surgery. The enemy is scarring and how you get around that. Okay, the referral criteria, it goes through a few things. This is used by the Australian New Zealand Burn Association, and an easy way to remember it is SPAM. You only need to get one of any of these. More than 10% total body surface area of any type of burn. So from the rule of nines, your entire upper limb is 9%, and the palm of your hand is 1. So if I burn my entire upper limb plus a palm of my hand, that's enough to pick up the phone and ring someone. A child is half that, not because they are more physiologically unstable, but that's happened in a context. Something has not protected that child to the point where they've burnt that much, and a phone call needs to be made. More than 5% full thickness. If there's a pre-existing illness, if there's pregnancy, if there are extremes of age, there is no definition of what extremes of age are. Okay, it is super loose. I use the thing. Pediatric patients, anyone shorter than I am. A geriatric patients, anyone older than I am. You can use your own definitions. Special areas: face, hands, feet, perineum, over major joints, anything circumferential, or the lungs is a very special place. And then the weird mechanisms. Go through that, and you're almost picking up the phone for everything. And the important thing here is about picking up the phone and talking, not necessarily sending the patient on. Okay, so Harold Gillies, who was the modern father of plastic surgery and actually a New Zealander, really hit onto it. It's about a team, and I'm so pleased to see so many members of the burn team actually here today. And it's by working together that we can actually get good results for a major burn patient. Up until about 11 years ago, the burns that, the people that you would ring lived in the regional plastic surgery units, which are also the regional burn units. They are in these 4 cities, okay? And we got on about as well as these guys got on with each other. We were ultra competitive. We couldn't stand each other. And then about 11 years ago, so before my time, there was talk about how does a country like New Zealand with limited resources treat these very rare but very devastating problems. And, oh yeah, that's just to demonstrate how much we don't like each other. Right, and the likelihood of us working together would be about the same as an All Black coaching the Wallabies. That's how old this slide is, right? And for those of you who don't know, that's Robbie Deans. He was an All Black, and he ended up coaching the Wallabies, and they actually did better under him than they're currently doing. But moving right along, between the Ministry of Health and ACC, we were able to get a framework up to establish the National Burn Service, of which the National Burn Centre is a part. So the idea is that instead of having all these regional teams, you have one coordinated network that provides the best care for all New Zealanders no matter where they are. That's where we put a TUI ad that says, yeah, right, but that's not quite right. Okay, established in 2006 with the National Burn Centre here in Auckland. There is actually an agreement, formal agreement between all the plastic surgery units, between our funders, which are basically in the Ministry of Health and ACC, and we work together to provide the best care that we can. Because it's that, critical, and this is the bottom line. The bottom line is this: optimal use of limited resources to achieve an optimal outcome. Okay. Right. We have agreed referral criteria, channels of communication, clinical pathways. And the things that we don't want to think about but are important are contingency plans. What do you do when things don't go right? And what I really don't like to talk about is where does the money come from? So some of the times the reason that we have to do things is because that's where the money goes. This is our current referral pathway, and it's changed from years past. What we've done now is that whoever has the patient in front of them can make the call to ring directly through to here, okay? And in years past, they had to go through their regional burn centre, but we found that that wasn't that efficient either for the regional burn centre, for us, or for the referrer. Because every year we review all the patients that we transfer and try and make things better. And there are some tools. Okay, here we go. Live demo. Hopefully this will work. HDMI laptop. And it's always dangerous when you hook up your phone to a thing, isn't it? How do I swap this over, guys? I'm on? Am I on? I'm looking at that screen. Oh, god dang it. Thank goodness there was nothing embarrassing on my phone. Shit, that would have been really bad. Okay, go to the App Store, download something called NSW Trauma. In the grand tradition of New Zealanders and Australians, the Australians paid $500,000 for this. We said, hey man, can we join you? How much are you going to pay? Nothing. Okay. So we got in for free. Okay, right. As you can see, there's a whole lot of stuff. There's actually a burn section. So it's now downloading. Let's hope we have it. And you'll see down here, New Zealand specific content. And you exchange it. And we have a referral form. Everyone goes, oh, where the hell is it? It's on a website. Well, actually, you know what? You can download it, and here it is. You can't fill it in online, but you can email it to yourself. We have other guidelines, such as the referral pathway, so that picture you saw before. But the real value of this, and the reason that we've jumped onto this, is this little thing, the calculators, BSA and formula for an adult. Let's say someone weighs 60 kilos, they've had no fluid coming in, it's an hour since they've been burnt. Are you sure? Yes, I'm sure. I wouldn't have done it otherwise. Picture of a person. Wouldn't it be really cool if this could calculate how much burn area it was by shading? But what about the back? Wouldn't it be cool if we could zoom in? Uh-oh, I've made a boo-boo. Okay? The Australians spent $500,000 on it. We made a phone call, they let us on. So it's available. And with time, we'll hope to improve the functionality of that. We'll just switch back over to this. Thank God that worked, and thank God nothing embarrassing came on my phone during that period of time. So far we've treated over 3,000 patients. About 125 have come from other parts of the country. But probably more importantly is that we've helped train 10 fellows. That's a fellow a year, and I've actually got fellows lined up coming here through till 2019. And the other thing is that it allows us to play with some bits of equipment and new technology that has flow-on effects for other services. Right, I'm almost out of time. So, has it made a difference? Doesn't project very well, but what we've done is, excluding deaths, that the length of stay for each size of burn has decreased now compared to what it used to be before. These are some mortality stats, and basically what I want to point out here is that prior to the National Burn Service, in this hospital anyway, no one over a 70% burn had survived in the period from 2001 to 2006. And from this period, which is 2006 to 2011, so excluding the last 5 years, we had an LD50 of about 80%. So if you came in with an 80% burn, you had a 50-50 chance of making it through. And more importantly, the 70 to 79%, we had a 75% survival rate. Small numbers, but better than zero. Okay, right. For those of you who work in the operating room, you know that the burn theatre should traditionally be really hot. Okay, I always believe you should warm the patient, not the room. And what we've done is we've bought a whole bunch of, which n equals 1, so that's a whole bunch, right, of water heaters. Now, there are bigger ones that will both heat and cool, but this will solely heat. And this is small enough that you can tuck it under the table. And it was originally bought for burn patients, but now I have to fight for it because anyone doing a long procedure, so that includes spines, that includes my colleagues doing free flaps, will put these in to keep their patients in a better physiological state during a long period of anesthesia. We use a lot of things to minimize blood loss, so we have powered infiltration units that go through heated systems, plus another way of debriding a burn wound, which is using a water jet instead of which uses a blade of water rather than a steel blade. Okay, and with a whole lot of things, we've halved the amount of blood that we give a patient during their first week and throughout their stay. Video won't play. We've used a lot of skin substitutes, so in the past these are exposed tendons, you need to put something over that, and traditionally that's been a free flap. You can use some dermal substitutes that we use a lot of in burn surgery, which is now flowed on, and you can graft that quite simply. Okay? It takes a little bit longer in terms of hospital stay, but certainly a lot less time in terms of anesthesia. Infection's always been a big problem for us, and these things which look like refugees from a Doctor Who program are called, is a BioQuil system. What that does is sterilize a room with vaporized hydrogen peroxide, okay? And this little thing is a little monitor that sits outside the room to see what the concentration is. Now, what's really interesting is that we bought the Rolls-Royce version of this. Auckland City bought the cheaper one. Anyone here from Auckland City? I'll be very careful what I say. You're going to record this, aren't you? You made a good choice, Auckland City. They worked out whether or not their system worked well enough or not, but they didn't know how much hydrogen peroxide was in the room. So they had to borrow our monitor, which is part of our system, and then they chose a system that didn't need it. I'll just let that sink in and percolate. But anyway, okay. It doesn't project well, and I do apologize, but the slides and petri dishes on your left are what we could grow after a terminal clean. So what a terminal clean is when not just someone goes around and just sweeps the floor ready for the next guest, right? But this is the cleanliness that you get when you say someone infectious with a multi-resistant organism has been in that room please clean that room ready for the next patient. So this room is cleaned within an inch of its life, and here we are culturing stuff out of it. The one next to it is what happens after a terminal clean that you put in the biocoil and then re-swab it. Essentially, there's nothing there. And this thing that was originally bought for the burn service now does a tour around the hospital to make sure that our patients go into rooms that are as clean as possibly could be. I feel like I should take one with me when I go into a hotel sometimes. Okay, I'm kind of out of time now, but I thought it's after lunch.
You've got till 2:30.
I got to, what?
Another 8 minutes.
I've got another 8 minutes. Okay, all right. Okay. Is there anyone here who doesn't work at Middlemore? Okay, fair group. Okay. I got a, Middlemore is a special place in a special part of Auckland. This is grab one, okay? What you can't read from here, this is in Epsom. You can get a sumptuous 3-course degustation menu, okay? In South Auckland, oh no, that's Auckland, yeah, what's that? That's a 6-course degustation menu in Epsom, okay? In South Auckland, you get a bucket of fried chicken, okay? We have very special patients here at Middlemore. What you can't read here is there is a 19-year-old woman comes in at 14:46 and she's got abdominal pain, PV bleeding, and just something or other. And then at 15:56, 15:58, and 1500 are 3 young men with discharge coming in. Contact tracing at South Auckland is quite easy. I mean, some of the patients that we have are just amazing. This is a guy's name is Boss Man. Could someone please call in Boss Man? Okay, we have acute lists. If you think you're busy in your hospital, this is in the old days when we used to have bits of paper, right? These are the people who on that day are waiting for an acute operation here at this hospital. You know, you are here. Your call is important to us. Please hold, an operator will be with you shortly, may be monitored for teaching purposes. Okay? The place is special. This is the entranceway into the National Burn Centre, and you know, there's the prerequisite alcohol gel. I complained that every morning I had to go in and stand on tiptoe to reach this thing. Okay? So they put one down low so I could reach it. In the old theatre block, there was a leak in the theatre tea room, so we rang engineering and said, hey guys, there's a leak. Can you come fix it? Sure, no problems. Yep, they've got a drip tray and a hose going out the window. Problem sorted. Welcome to Middlemore. Okay, this says, you can read what it says, right? This is when we were planning for the new burn theatre. You can have a chart. What does that say? It says flick. Flick. Flick, guys. Flick. I don't know what you were thinking. It's quite obviously flick. Is the illustrious leader here? No, he's not. He's gone back to... Okay. I mean, this is our intensive care unit who, when a child was about to wake up, they thought they would suspend the toys so that when he woke up, he'll be pleased to see them. And... okay, this kind of shows how old the slide is because that was my phone. Okay, what we were doing a case and we need to get the burn fellow in. You can't read it, but it says, "Hey chef, call the Chinaman when you can be asked." This is what happens when you ask your anaesthetic colleague to please page the burn fellow. These are some members of the burn team. I have no words. Okay, I have some extremely special colleagues in the Department of Plastic Surgery. They cannot help themselves but be cosmeticians. This is a patient with graft versus host disease, and this person is, yes, putting on nail polish. For this little girl, you know, we're trying to protect the gene pool. That was his parting gift from us. I asked my registrar, can you please jump in the tub and scrub up? So she jumps and puts her knee in. I mean, I don't know about you, Murray, but I have to work with what I have to work with. I have some incredible colleagues who will not only do they glue themselves, but for those of you who don't know, that's a loop box. That's where we store our surgical loops, magnifying glasses, and he's pimped it. He's put his own sound system in there. I work with this guy, it's so sad. Okay, And we have some grateful patients. Now, this man, he's walking up there, is 25 years old. He sustained an 85% burn, and he had a 4-week-old daughter when he came in. These were the hospital notes that were generated in his stay. This is a list of the operations that he had. Okay, he spent over 100 days in hospital, over 30 of them in ICU, and he walked out of here. Okay, and there's him with his daughter. Okay, and he said, "Thank God there was an excellent doctor in Tauranga who saved me." Anyway, so maybe this isn't an appropriate slide. Look, thank you very much for your attention.